are live. Hello everyone and welcome to the Melanin Initiative. In healthcare, there is often too much information and not enough time. Here at the Melanin Initiative, we avoid TMI by breaking things down into language that you can understand. We create a safe space for you to ask your questions and for us to share our nursing perspective without taking too much of your time. On today's episode, we'll be talking about contraception. We'll be discussing different methods of contraception and how they work, common myths about contraception, considerations when choosing contraceptives, challenges and concerns, as well as the importance of education and advocacy. If you're new here, once again, welcome to the Melanin Initiative. I am Geraldine and one of the co-hosts here at the Melanin Initiative, along with Kimberly and Alisha. We are a health literacy podcast offering our nursing perspective. When we say health literacy, we're talking about the ability to obtain information, to understand that information, and to use that information to manage your health and advocate for others. By watching on YouTube or LinkedIn and listening on your favorite podcast app, we hope you feel empowered to ask those questions, educated on how to manage your health, and confident to navigate our healthcare system. If you haven't already, subscribe so you can be notified when we release a new episode. Thumbs up the video and leave a comment or two. It helps us help you. It also shows YouTube this content is valuable and helps to make sure YouTube shows our content to those who need to hear it. As a reminder, this show is for educational purposes only. The opinions expressed are our opinions alone, and they are not a representation of any of our affiliations. If you're experiencing a medical emergency, you should seek medical attention and medical guidance from a healthcare provider. If you're having a physical emergency, please call 911. And if you're having a mental health emergency, you can call 988 or text 741-741. So let's get this show started.
Thanks, Geraldine. Welcome, everybody.
Welcome back, ladies. It's been a while since they've seen you, and they know you send your love. My mom says, how are the ladies sending their love?
Oh, God. We're always there in spirit.
Yes. Yeah.
Well, as we do in all of our episodes, we're going to start with the definition. So you may be wondering, what is contraception? Contraception is defined as the intentional prevention of conception through the use of various devices, sexual practices, chemicals, drugs, or surgical procedures. Conception is the process of becoming pregnant. So there are various contraception methods, and those include condoms, female condoms, oral contraceptions or pills, hormonal rings, UIDs, contraceptive injections, surgical sterilization, implants, coitus interruptus, calendar rhythm methods, vaginal douches, contraceptive patches, and diaphragms or caps.
So we're going to try out something different with this episode. We're hoping that you see a big graphic somewhere on the screen to make this conversation a little bit easier to understand. I noticed in that graphic, and Geraldine was trying to say,
yeah.
It says UIDs.
I was like, maybe that's something new that I had never heard of.
But that's a photo of an IUD.
An IUD, yes. Okay.
So we're going to call it IUD for this conversation.
Yes.
And so, we're going to go into different methods and how they work. So the first one, IUD, also known as intrauterine system, is that small T-shaped device you see on the top row. It's placed inside the uterus by your provider, which can be a physician, a nurse practitioner, or a physician associate, usually practicing or specializing in women's health. Mm-hmm. It releases a small amount of progesterone each day to keep you from getting pregnant. It stays in your uterus for up to 3 to 8 years, depending on which one you get. Mm-hmm. So we're going to talk about failure rates. I guess we couldn't really talk about success rates. So this has a really high success rate. Has a high success rate. So only failure rate is about like 0.5%. I don't think people will understand what that means. Then there's the copper T IUD. It's a small device, also the same shape as the T, and then you and your provider can determine which one is the best one for you. The great thing about that one is it can stay there for 10 years, and the failure rate is pretty similar.
And also with just to chime in here, the copper IUD, it's non-hormonal in comparison to like the other ones like the Mirena and the Kyleena. Those have the progesterone hormone, but the copper one does not have any hormones in it. Another thing with the copper IUD, some women may experience heavier bleeding with the copper IUD, just an FYI.
That's very good information. So speaking of hormones, let's talk about some of our hormonal methods. So we have the implant, and that is a single thin rod that's going to be inserted under your skin of your upper arm. It also contains progesterone, and it's released into your body over the course of 3 years. Again, a pretty similar failure rate, so really, really high. Pretty much 99% success rate with that one. You have the injection. I think a lot of people know it as the depot shot.
Yep.
Women get this shot of hormone progesterone in the buttocks or your arm every 3 months from your provider, and this success rate is about 96%. Then we have our combined oral contraception, also known as your birth control. This is the pill. It's a combined oral contraceptives that contain hormones, estrogen, and progesterone. You get a prescription from your provider. So again, that's your physician, NP, or PA. And you take a pill at the same time every day. We want to point out that if you're older than 35, you smoke, and you have a history of blood clots or breast cancer, then you may not be advised to take the pill. The success rate on this is around 92%. Those women with high blood pressure, which is typically 100, your top number systolic, 140 or above, or the lower number or diastolic, 90 or above, with breast cancer, known heart disease, migraines, with aura, or like right before your migraine, you get other symptoms that usually happen every time you get that migraine, and you kind of know, okay, every time I get nauseous or every time I get lightheaded, a migraine's coming on. That's what we mean by aura. So if you fit into this category, endometrial cancer, cirrhosis, hepatocellular adenoma, or something wrong with your liver, or malignant hepatoma, then you would be not a good candidate for these options. And so it's always really good to know your history and to be honest and transparent when they're asking you those questions up front on whether to find out if you're a good fit. Because as you can see from our graphic, there's a lot of options. And so if one doesn't work out, we have a lot of other ones to choose from.
Absolutely.
So speaking of options, there are times when you're taking the pill, as we've called it, and you are not able to take estrogen for maybe some of these other reasons that Kimberly just mentioned. There are progestin-only pills. So unlike the combined pill, which has estrogen and progestin, the progestin-only pill, sometimes called the mini pill, only has one hormone, progestin, instead of both estrogen and progestin. Mm-hmm. It is prescribed by your provider, and it is taken at the same time each day, so the same rules apply. Mm-hmm. It may be a good option for women who can't take estrogen. So the success rate is still around 92-93%. You can also have the option of having a hormonal vaginal ring, which you may also have heard as NuvaRing. And this is a contraceptive ring, and the ring releases the hormones progestin and estrogen. And you place the ring inside your vagina. You wear the ring for 3 weeks, and then take it out for the week that you have your cycle or your period. And then you put a new ring in. And this also has the same success rate of about 92-93%. And another option is the patch. As you can hear, there are plenty of options. This is not a one-size-fit-all kind of situation, right? So there's also a patch. This patch is to be worn on the lower abdomen, buttocks, or upper body, not on the breast. And this method is prescribed by a provider. It releases the hormones progestin and estrogen into the bloodstream. You put on a new patch once a week for 3 weeks, and during the 4th week, you do not wear a patch, so you can still have a menstrual cycle or a period. And this also has a similar success rate of 92-93%.
And now we'll talk about barrier methods. The most common barrier method is the male condom. That is worn by a man. A male condom keeps sperm from getting into the woman's body. Latex condoms are the most common types of condoms that are found, and they help prevent pregnancy, HIV, as well as STIs. There are people obviously that are allergic to latex, so there are options. Like Alisha said, there's plenty of options. So if you are allergic, or if you or your partner are allergic to latex, there are some other natural or lambskin condoms that do the same thing, that can help prevent pregnancy. However, I would like to point out that sometimes the natural or lambskin condoms may not protect you as well against STDs and HIV. The typical failure rate for male condoms is 13%. Also to note, condoms can only be used once, so once it's used, they have to be discarded. Another contraception or barrier method is the female condom. This one is worn by women, and it helps keep sperm from entering the body just similarly to the male condom. It is packaged with a lubricant and is available at drugstores. It can be inserted up to 8 hours before sexual intercourse, and the typical failure rate for this one is 21%. Another barrier method, which is less common but still used, is the diaphragm or cervical cap. Each of these barrier methods this barrier method is placed in the vagina to cover the cervix to block the sperm. The diaphragm is shaped like a shallow cup, and the cervical cap is a thimble-shaped cup. So both of them are have a cup shape, but essentially it goes over the cervix. Before sexual intercourse, they're inserted. You insert them with spermicide, and spermicide is a solution or a ointment, not ointment, how do I say that? It's a topical, thank you. A topical that basically blocks or kills sperm. So you would have to visit your provider, your healthcare provider, for proper fitting, because diaphragms and cervical caps come in different sizes. So definitely talk to your healthcare provider about what is the best option for you. The typical failure rate for this is 17%, so a little bit of a higher failure rate. Just point that out. The sponge is another one, not very commonly used, but it contains spermicide as well, which is the topical that's used to kill sperm. And this one is placed in the vagina where it fits over the cervix as well. The sponge can work for up to 24 hours and must be left in the vagina for at least 6 hours after the last act of intercourse, at which time it is removed and discarded. And the failure rate for this one is 14% for women who have never had a baby and 27% for women who have had a baby. So it's has a pretty high failure rate, especially for women that have already had a child. And then we already spoke about spermicides, which is once again the topical. It comes in a foam, gel, cream, film, or suppository, or it can come in tablet form as well. And you can place the spermicide itself in the vagina no more than 1 hour before intercourse. You leave this in place at least 6 to 8 hours after intercourse, and once again, its goal is to kill the sperm.
So I know we threw a lot out there at you. So the important takeaways, there are lots of options. And as we like to say here, it's important to stay in contact with your primary care provider. And if you so choose, to maybe find a specialized provider in contraception. So maybe going to see a gynecologist or some of the sort, so that you can get the best support that you need. And I would also say it's important to be honest with yourself and to know what's going to work best for you. You know, some people know that taking a pill every day is not going to work for them. So perhaps maybe having a pill-based contraception isn't for you. Maybe you should do more of the long term. Or maybe, you just got married and you and that partner are looking to have children right away. Maybe putting in that long-term IUD is not going to be the best option for you. So it's all about family planning and doing what's best for you. So along those lines, understanding your monthly fertility pattern can help you plan to get pregnant or avoid getting pregnant. Your fertility pattern is the number of days in a month when you are fertile, which also means able to get pregnant, and days when you were infertile, and days when fertility is unlikely, but possible. If you have a regular menstrual cycle, you have about 9 or more fertile days each month. If you do not want to get pregnant, you do not have sex on the days you are fertile, or you use one of the barrier methods that we just previously described. Failure rates across these methods, typically 1 to 2 range of typical use. Sorry, I'm a little lost here, hold on. If you use a barrier method or birth control on those days, let me back up a little bit. if you do not want to get pregnant, you do not have sex on the days you are fertile, or you should use a barrier method of birth control on those days.
Right.
Failure rates across these methods range typical use
2 to 3
to 23%.
Yeah, so in terms of how successful is it, like how reliable or dependable is it, then, I think that people understand that a little bit better. So that's around 80%. So 20% chance you can get pregnant. It depends on, your risk tolerance. But yeah, I think as we went down the list, the success rate went down. That's what it seemed like. Yeah.
Right.
And then you pointed out something really important, Geraldine. Did you talk about when they use condoms not to use these oil-based lubricants and stuff?
No, I didn't.
Because I don't think people, that could set the mood, and so sometimes people might think, the more the better, but that's not always the case.
I missed that. So yeah, regarding like the male condom usage, a lot of people tend to use lubricants like KY jelly or water-based lubricants that are found at your typical drugstores. It's actually not recommended to use those, or especially the oil-based lubricants, such as, let me backtrack. So it's actually not recommended to use the oil-based lubricants, which includes massage oils, baby oils, lotions, or petroleum jelly with latex condoms, because they can actually weaken the condom, causing it to tear or break.
Which would really lower your success.
Exactly.
It would increase your chances of getting pregnant significantly. So yeah, again, more is not always better. So again, talking about ways that you can reduce your risk of getting pregnant, we have the lactation amenorrhea method. So for women who have recently had a baby and are breastfeeding, this method, also known as LAM, can be used as a birth control when you meet these 3 conditions. First of all, you're experiencing amenorrhea, which means that you haven't had a period after you delivered your baby so far. You're fully or nearly fully breastfeeding, which I don't know if there's a numerical value. How do you know if you're nearly doing it? How would someone know that?
If they are, like, let's say some people supplement with formula. That's my take on it. So they might not be like breastfeeding solely.
Oh, okay.
Yeah.
And then it's been less than 6 months after you've delivered your baby. This is a temporary method of birth control, and we highly recommend that you combine it with another form of birth control that has a higher success rate, especially if any of those 3 conditions are not met. And then I was really curious about the success rate on this one. And so it said that the LAM or the lactation amenorrhea method of family planning is considered 98% effective against pregnancy for up to 6 months after you give birth, if you use it perfectly. Whew.
Yeah.
This means
that's like the stars have to align.
It's such a hard time just because of that postpartum period, and you're doing so much and trying to, just get it right. But you're working in a new baby, expanding your family. Maybe you're going back to work within this 6 months. So you really have to take this under consideration really carefully. So yeah.
Yeah, because I've definitely had patients, although I'm not like a women's health. Yeah, in PED, like I've had patients in the family setting that just came for something different, and we had that conversation where they
heard about it,
or no, they got pregnant even though they were. So it's not 100%, because you still can get pregnant even though you are breastfeeding. It's less likely, but it's possible.
And yeah, that's it. So for NPs who specialize in women's health, when they go to NP school, they pick that particular track, and so their certification is Women's Health Nurse Practitioner. But you can also be seen by a family nurse practitioner too.
So I do have like women's health training, but I just don't have training with like OBGYN, pregnancy. But I have like the other training though.
So they only do women's health things, whereas Geraldine can dibble and dabble, however she desires.
A little bit of everything. But moving right along, another form, we're going to talk about emergency contraception. So this is actually something that I learned as I was researching about the topics for this show. I was unaware that you can use the copper IUD as an emergency contraception. commonly we hear like the Plan B,
Right.
Or the drugs similar to Plan B that are out in the drugstores. However, the copper IUD can be used as emergency contraception if and only if it's implanted within 5 days of having unprotected sex. So, if you're lucky and you can get in to see a provider, exactly, because a lot of times you can't get in to see a provider that quick, like especially like a women's health provider within 5 days of unprotected sex. So I wouldn't count on that method, but it is a possibility. If it's placed within 5 days of unprotected sex, it can be used as a form of emergency contraception. And then, like I stated before, the most common one is the pill, the Plan B pill. However, this also needs to be taken within 5 days of having unprotected sex. Also, I just want to note that the Plan B, there are some like weight restrictions to it. I want to say I believe it's if you weigh more than 150, it's not as effective. Yeah. And it's
changed over the decades.
It has.
I heard that when it first came out, you had to get counseling. Do they still do that?
No. You can go into the store.
And that changed too.
You don't need a prescription.
You needed a prescription. Now it's on the shelves. A lot of times it's locked, but you can definitely just go into like any CVS, Walgreens, any pharmacy-based store and just ask for it, and they can give it to you with no prescription needed.
It's a heavy dose of hormone.
It is. Yeah. So it can come with some
don't always
side
feel
effects.
the best.
Yeah, it comes with side effects, GI side effects.
It's a lot. Yeah.
So just keep that in mind.
Yeah.
Alrighty. So, we are going to move right along to our next stage of contraception, and this would be our permanent methods of birth control. So, if these next couple of things are if you don't want to have any more children ever. So, first would be female sterilization, which we also call tubal ligation, or getting your tubes tied. That's probably what you've heard before. It is a procedure that takes place, and they tie your fallopian tubes, which I don't have a picture to show right now. However,
we'll work on that.
If we find one, you'll see it here.
Yes, but yes, your tubes get tied, and it does not allow that egg to travel down into the uterus to allow you to the sperm to meet the egg to get you pregnant. Okay. Then the other side of that would be male sterilization, which is also known as a vasectomy. And both of these forms of permanent method, like they're permanent. However, could technically be reversed. However, it depends on how the procedure is done. However, most people that are seeking these methods have come to the realization that they do not want children anymore. So
or at all.
Yeah. At all. Correct. It doesn't have to necessarily be for the beginning. Now, I will say a lot of times if this is what you're going through or what you're trying to decide, your provider is going to ask you questions, and it's not going to be an easy thing. Your provider is going to ask you lots of questions and make sure this is really what you want to do before they move forward with that procedure.
Speaking of that, I had a friend or a family friend that she was, I don't know if there's a criteria that you have to meet age-wise, but she was less than 30.
I was going to say, the younger you are, the more they're going to encourage you not to do it.
Right, because she was definitely younger than 30. She had 2, and she said, I'm done, I don't want to have any more. But because she was under 30, like she was like maybe 28, 29, or 27, 28, her doctor said no, because just in case you change your mind and want to have, she's still set on not having any more, but providers will highly recommend and advise that you not do it if you're before a certain age.
I wonder if there's something in the guidelines for that.
Yeah.
We'll take a look at that.
We will put in the show notes.
Yep.
Yeah, so let's talk about some common myths, which we've kind of touched on a little bit. So there's one, especially when you talk about the umbrella of just contraception or like birth control, not necessarily the pill itself, but just like birth control methods. It seems to be given all the responsibility to the woman, or those who identify as female, is taking the responsibility, but really any person who's going to participate in sex of any body part, it has that responsibility. So that's the first myth. And then the second one is that it's only to prevent birth. And so, we use it to control heavy periods. If you have a lot of hormonal imbalances, like we talk about with our PCOS patients, we might use it to help you stay more regular. It's an option for people who have acne. We use it to prevent, what were you saying about STIs? Oh, so the myth is that it's only for birth control, but you can also, that it's only for birth?
No, you use condoms for only STI prevention.
Yeah.
Oh, yes. Right.
So condoms is not only to prevent birth, we also use condoms specifically to prevent STIs. It's okay, guys.
That's why when we talk to our older adults, we want to make sure they're included, because even though they don't, so oftentimes they're forgotten because it's like, oh, they can't get pregnant, so we don't include them in the conversation, but they should still be included because their risk for STIs is still present. And as we talked about, I think we did talk about in our STI episode, one of our most popular episodes.
We did, yes.
That, our older adults, our retired active adults are still very much active.
They are.
And they are coming to see Geraldine. And so, we just want to point that out too. And then, so when you're deciding on which one to pick, certainly be informed, do your research. We'll put some links in the description box, and you're going to look at all the things that we mentioned. What's the success rate? What's the likelihood that I can maintain this method, especially the one like the lactation one during that postpartum period? That's just a really tricky That's a hard time in the phase of your pregnancy to bet on that. I wouldn't bet on it. The side effects, like we mentioned, if you're a certain age, if you smoke, if you have certain conditions like high blood pressure, every medication always has side effects. We always want to point that out. Whether you get a prescription or over the counter, everything has side effects, and you have to decide for yourself if you're okay with those side effects. And some of those side effects are temporary. Once it gets in your system and you get used to it, a lot of times they can level out. It just depends on the medication and your health going into it. Think about accessibility. How often do you need to get it? And will you be able to maintain that if you want to maintain a sexual active lifestyle? And then your own lifestyle. Every decision has consequences.
Absolutely. I mean, but to that point though, I think people accessing contraception comes with its own challenges and concerns, and I would even say some controversy depending on, where you are looking to get it. So of course, side effects are a challenge to birth control, and depending on the method that you choose, there could be, it could cause nausea, headaches, changes in libido. And then for, I know plenty of, so a few of my friends have had significant like hormonal and like mental health changes, depression, anxiety,
mood swings
for sure. And even with all the methods that we chose, there's different brands of methods. Even with there could be a pill, but there's different brands of pill, and maybe one brand works better than the other, and all of those things have to be considered, and could be a challenge because you tried one pill and that didn't work well. Then you tried a different pill and that one didn't work well. Then you went to the NuvaRing. Then you tried an IUD. So that can be anxiety provoking to have to try all these different methods to find the one that works best for you. Accessibility. There could be limited access to certain methods depending on your socioeconomic background or what you're going through in your life at that time.
Your income.
Insurance.
Yep, insurance for sure. Right.
Yeah.
Different cultural or religious beliefs.
That's a big one.
Yes.
Yeah.
A little bit political now too.
And political, absolutely.
Oh,
yeah.
Oh, yeah.
Yeah, for sure. Yeah.
Unfortunate.
I mean, I even know certain health systems that the providers may provide contraception, but because that health system has a certain religious affiliation, they will not provide you with contraception. So it's also important to know where your health system stands on a lot of these different topics.
Absolutely.
And then also education and awareness. So misinformation and stigma can also prevent people from accessing contraception. And that's why we're here to break down those myths and stigmas.
Yeah, and so as we wrap up, we just want to talk about what we all can do to improve awareness and education when it comes to contraception or birth control methods. We want to encourage you to be open and honest with your providers as well as with yourself and the other people in your life, because not everybody wants the same thing.
Yeah.
We want to promote comprehensive sexual education in schools and communities. And again, that's going to come down to the state and sometimes the county that you're in on whether that's accessible, and then what they're actually covering, right? And so there are some credible resources out there. We'll put some of those in the description box. But just remember, your counselors, your teachers, the people at your church, maybe your neighbor, maybe your family has friends who are in the healthcare field. They would be more than willing to sit down with you, direct you in the right direction, provide those resources for you. But we won't know you need them unless you ask. And we assume everyone's doing it, but we just hope everyone's doing it in a way that's responsible and safe. And we want to advocate for reproductive rights and access to contraception for anyone who wants to use it. And one thing we like to do here, the three of us, we're 3 Black females who are straight. And so we always want to make sure we bring attention to the people who aren't sitting at our table. And so we have a list of vulnerable populations that we like to draw attention to. We've covered some of those today. We didn't really cover the LGBTQ community, but when it comes to gender and contraception, it's not really going to be associated with your identity. It's going to be associated with your body parts. So whatever body parts are still present, those risks and available contraceptions will be associated with those body parts. We talked about age and we talked about gender in terms of saying it's not just the woman or the person who identifies as female as being responsible for that. Socioeconomics. I think it's important. And so the multilingual, right? So if we're in a position of educating or prescribing or treating patients, we want to make sure that we're providing written or narrative information, even audio, that's available in the person's language that they receive it in. And that just requires us to ask and make sure they understand. If we know for a fact they speak another language and they can get through the conversation that we're having and it seems okay, but for this, you want them to make sure they have it in the language that they really understand, that they can take back home and talk with their family. That's really important. I think that covers it.
All right. So to wrap us up for today, we discussed what contraception is, different methods of contraception and how they work, different common myths about contraception, considerations when choosing contraceptives, challenges and concerns, and the importance of education and advocacy. So as always, you can email us your questions or show ideas at tmi.melanin@gmail. If you haven't already, subscribe to our YouTube channel and follow us on every social media platform. Say hello in the comments when you get there. Please share the show with your friends, rate the Apple Podcasts and Spotify, and leave a comment. It really helps the show get more support and gets the message out there to those who need it. You can find all of our social media links and a list of resources related to our conversation today in the description box. We release a new show weekly on TMI Sundays at noon Eastern Standard on YouTube and all your favorite podcast apps. Follow, like, and share our content with all of your friends. And thank you for watching.
Bye.
We'll see you next time.